You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello, and welcome to the Lipid Legends podcast series. This continuing education series is supported by educational funding provided by Amgen, Arrowhead Pharmaceuticals, Novartis Pharmaceuticals Corporation. I'm your host, Dr. James Underberg, a clinical assistant professor of medicine at the NYU School of Medicine and the NYU Center for the Prevention of Cardiovascular Disease. I also direct the Bellevue Hospital Lipid Clinic, and I'm past president of the National Lipid Association. And today, I'm lucky enough to be joined by a friend and colleague, Dr. Zahid Ahmad, who is an associate professor in the Division of Endocrinology at the UT Southwestern Medical Center in Dallas, Texas. Dr. Ahmad is well known in the field of clinical lipidology and also expertise in the area of focus tonight, which is going to be lipodystrophy. In this Lipid Legends podcast series, I'm interviewing expert physicians and researchers on topics that are of current importance in the field of lipidology. And today, we'll be discussing the topic of lipodystrophy. So, Dr. Ahmad, we'll call each other by first name. So, Zahid, I'm James, or Jamie. Thank you so much for being here. It's great to have you.
Yeah, thank you, Jamie, for having me.
So, I want to jump right in and start off with my favorite question was, how did you end up first in the field of endocrinology and then ultimately with a focus in the lipid world that is how we know one another?
Yeah, so these are turning points, I guess, in residency and in fellowship. So in residency, I had narrowed things down to cardiology or endocrinology. And I ended up choosing endocrinology for two reasons. One, everyone in my family has diabetes. They also have premature heart disease, but diabetes, premature heart disease, and I felt like endocrine might give me a better leg up on studying that. Then the other reason was our residency was heavy in cardiology, and I was so tired of seeing patients with chest pain. And I mean, back then we were doing all the procedures too. I would float Swan-Ganz, catheters, and all these things, and I was like, I don't want to do this, and so that kind of made that decision easy for me. And then in fellowship, so our fellowship at the time was 1 year clinical and then 2 years research on an NIH T32 grant. And I chose a mentor, Abhimanyu Garg, who is the world's expert on lipodystrophies. And I had some other mentors too, Scott Grundy, Helen Hobbs, Jonathan Cohen, the people who are the true lipid legends. I mean, it was really amazing to be around them and learn from them. But from Dr. Garg, you know, it was a fascinating experience. I think it's what the NIH experience is or what Mayo Clinic, because people would come from all over the world and they really just wanted Dr. Garg to say yes or no, you have lipodystrophy. But they would come, we would spend days with them, do some really deep phenotyping. I learned how to do an exam, a physical exam that's beyond anything we learned in medical school. We would do these family studies, we do genetics, we do all kinds of studies to understand their body fat distribution, whole body MRI, underwater weighing, all kinds of stuff. We did all kinds of metabolic studies. Like I even did a few euglycemic hyperinsulinic clamps, which is not my favorite thing to do. It takes all day long. It was horrible, but it does give some valuable information. And then, we did lots of clinical trials, mostly of leptin therapy, but of other things too. And then with Dr. Garg, I had two main studies. One was of people with zinc metalloprotease deficiency. And that's a protein that's very important to convert pre-lamin to lamin. And people with lamin problems have lipodystrophy. They have a partial lipodystrophy. And then I also spearheaded a clinical trial of testing cholic acid for fatty liver disease in people with lipodystrophy, which, since you haven't heard about that, that didn't really work out too well. But it was an interesting idea, and now there is something similar, obeticholic acid, that has been tried and works for fatty liver disease. And then while I was doing all that, my mentors like Scott Grundy and Helen Hobbs kept telling me that I had to have my own projects too. I couldn't just ride on Dr. Garg's coattails. So, in that regard, would tell me just come to lipid clinic and just study what you see. And so I would go to lipid clinic with him, and we had all these patients with extremely high cholesterol, LDLs of 300, 400 sometimes. And this was in the about 2008 to 2010 or so. There was nobody studying familial hypercholesterolemia at the time. And so, and all the studies that were published were either out of Europe or out of Japan. And I even remember I went to Dr. Gard and Helen Hobbs once and asked them, like, is FH a European disease? Like, what is this? Why is there nothing in the rest of the world? And the advantage we had at our center was that we saw a very diverse group of people. So we developed a protocol to study minorities with FH and the genetics specifically. And so when I finished fellowship, I joined faculty. I got a NIHK award to do exactly what I just mentioned: study the genetics of FH in minorities and their families. Our goal was to find a new FH gene, which at the time seemed feasible, but in retrospect, that was way too ambitious. But it was still a great experience. I learned a tremendous amount, and even the grants I have now still build upon what I had learned back then.
It's fascinating to me that every time I do these interviews, people tell me their story, and it's usually one person that they touched or connected with who altered the trajectory of their career. Uh, and you're so lucky to have met Dr. Garg, who we all know in this space. So, of all of these things, what career achievement would you say you're most proud of?
Well, it's something that nobody ever remembers about me. But back in 2008 to maybe 2012 or so, we had published a series of papers on FH that basically laid the groundwork for what is FH in the US, what is the scope of it, what are the health disparities. And that started with some of the NIH grant work that I did, understanding the genetics in minorities. And then it expanded to working with like the Family Heart Foundation. Back then they were called the Familial Hypercholesterolemia Foundation, and they had a nationwide registry. And I was the first or the last author of the first 3 manuscripts out of that registry. They kind of help characterize, how are these people being identified, diagnosed, what are they being treated with, what LDLs are they achieving, and it was abysmal. And this is data from lipid clinics across the country. The LDLs were still 140, 150 on treatment, and that and there was also disparities. Unfortunately, there's many groups. However you want to divide it, by race, gender, socioeconomic class, doesn't matter. You'll find all these disparities out there that we really need to work on. We still don't have a good answer for, but maybe one day we'll be able to fix it and kind of level the playing field for everyone. But I really enjoyed that work, and that is what I try to emphasize to people as my favorite work, because nobody else was doing it. I would go to meetings and nobody would come to my poster. And then when the PCSK9 inhibitors started coming around, all of a sudden I got super popular. I was getting invited to meetings to give talks, and it was a totally different world. Everybody cared about FH suddenly. And now in 2025, everybody and their mom is a FH expert.
It's interesting. We were involved in those registry trials at Bellevue, and we're part of the Family Heart Registry. And I remember looking at that data and being so dismayed at how we were doing as expert centers in taking care of these patients. So let's jump right in at the topic of hand, which is lipodystrophy. Can you give us kind of a brief overview? I know this is a complex topic, but kind of just a brief overview of the syndromes and why they're clinically important to recognize.
Yeah, so these are mostly rare disorders, but the prevalence is a bit probably not well studied. It's hard to study the prevalence because it's not diagnosed as much as it should be. But these individuals, people with lipodystrophy, they have loss of adipose tissue. Some are born without adipose tissue at all, meaning they have no subcutaneous fat. That's the generalized form. Then there are those who have fat in some places but not others, and that's the partial forms. And it's pretty interesting. The partial forms tend to be more acquired, whereas the generalized forms, at least the most severe one, is congenital, like it's something you're born with. There is an autoimmune version of that that's acquired, but all these individuals lose fat. They just either they're born without it or they've lost it later in life, and it's subcutaneous fat. And this is important because if you don't have subcutaneous fat, you store it in other places. You get fatty liver, you get fat in the heart, you get fatty pancreas, you get fatty kidney. All these things happen.
So it's redistribution of the fat as opposed to loss or absence of fat.
Essentially, I mean, it's a lack of ability to store fat in the subcutaneous space, and sometimes even in mechanical spaces like the palms and the orbits, that lead to kind of this. But what happens when you can't store the fat is you store it in other places, and you get all the manifestations of obesity. I mean, I learned more about obesity by studying lipodystrophy than by studying obesity. I mean, it's pretty fascinating what happens when you can't store subcutaneous fat.
So you alluded to these different types. What are the main subtypes of lipodystrophy if you were going to categorize them?
Yeah, I think you can categorize them in two broad ways. One is congenital or genetic, like is due to a particular mutation, and then acquired. And then the other way that we always do it is it generalized or is it partial? I think if you can look at it that way, that helps distinguish genetics and autoimmune kind of disorders.
Now, the acquired forms, what type of triggers could bring on the acquired form of lipodystrophy?
Yeah, so historically, the most common thing was protease inhibitors in people with HIV. And so that used to be, they used to be a very common referral to lipid clinic. And I don't know if you remember seeing those patients. They used to get these big abdomens because of all this visceral fat and the hepatomegaly they would get, and their arms and legs would be muscular. Sometimes they get the dorsal cervical fat pad, or we used to call it buffalo hump, and they have and they lose fat in their face. It's pretty fascinating what happened. And they would get triglycerides in the thousands, the worst diabetes. I mean, it was pretty. Now it doesn't happen because protease inhibitors are now just used as a booster in very low doses in the regimens, and not as the main therapy.
So once you see a patient or get referred a patient and you suspect the diagnosis of lipodystrophy, what are the type of things that you might proceed to confirm the diagnosis or guide management in that particular patient?
Yeah, it is still a clinical diagnosis for the most part, uh, but you could do genetic testing, and that helps you identify the congenital forms. There are many of the labs that do genetic testing have very broad panels. Often they call them dyslipidemia panels, and they'll include many of the lipodystrophy genes. Um, you can also, by examination, take a look at the person and see what the deal is. And obviously, you kind of look at them the same way you look at someone who is obese. Check for metabolic disease like their glucose levels, lipid panels, liver function test. In generalized lipodystrophy, you can look at leptin levels because it should be very, very low or almost absent. In the partial lipodystrophies, it kind of depends on how much fat they have left. But if they don't have much fat left, then their leptin levels can also be very low.
All right. So leptin can be helpful, but it's not absolute, correct?
Right, right, yeah.
So obviously, once we suspect it, is there any imaging that one might consider doing in these patients? Should they all have their liver examined for hepatic steatosis?
Yes, just like we might do for someone with abnormal liver test, all of these individuals should get some testing of the liver. You can do an ultrasound, you can do the elasticity type of testing now, just to see where they're at. And some patients with lipodystrophy do die of cirrhosis. So it is important to identify it early and then possibly do something about it. Now we have treatment for fatty liver disease, so or MASLD as it's now called.
So that leads into the next topic, which is how to manage these patients. And obviously, there's a myriad of cardiometabolic risk factors that one can address individually. So I was hoping you could talk about that, but then talk about any specific therapeutics that are directed towards patients with lipodystrophy, specifically
Yeah, let me start with metroleptin because this is a fascinating story. it, there's actually an entire story at UT Southwestern about this, and I imagine people outside of our institution have never even heard it. But these guys named Brown and Goldstein, they were the guys who discovered the LDL receptor, and they got Nobel Prizes for it. Well, they had developed a mouse model of lipodystrophy, and they had given the mouse model leptin and rescued it. And we're talking late 90s, early 2000s. They had rescued it. It pretty much didn't get all the metabolic complications of lipodystrophy. It was healthy again. And at the time, the people who made leptin or metroleptin were most interested in using it for obesity. People thought that if you give people leptin, it won't, it'll reduce your hunger and you won't get hungry and you'll lose weight. But it didn't work out. It's not an obesity drug, not by itself at least. And so they were actually very hesitant to give Detrogarg leptin, metroleptin, to try in lipodystrophy patients. They were giving up on the drug, but Detrogarg and the NIH put together a group, and Mike Brown from Brown and Goldstein pushed the company to give them the drug, and they did it. And they gave, I think it was just like 20 total generalized lipodystrophy patients. They gave them leptin, metroleptin therapy, and rescued them. And I had the opportunity to evaluate some of these patients like 20 years after those studies were published in the New England Journal of Medicine. And it was amazing. These individuals, some of them were on 1,000 to 2,000 units of insulin a day. And their triglycerides were still in the thousands, and their hemoglobin A1C was still 10. But with leptin, everything was normal. They were off of insulin. Their glucose levels were perfect. I mean, it was really quite amazing. They could go on a cruise. I remember one of them told me, I just went on a cruise and ate whatever I wanted. And and we saw them right after that, and they're, metabolically, they were totally fine.
So metroleptin is approved for folks with generalized lipodystrophy, correct?
Right. For generalized lipodystrophy only. It works for those patients for sure.
And their leptin levels are low, correct?
Their leptin levels are low. Yeah. And I should mention, leptin is a hormone. This is where the endocrinology part of all this comes in. Adipocytes, or fat cells, are not just these, passive things that store fat. They actually respond to the amount of fat in them and other stressors, and release different hormones and adipocytokines and things like that. And leptin is one of them that turns out to be very, very important.
So when folks with generalized lipodystrophy are treated with metroleptin, what are the clinical benefits that we see? Their glycemic control, their lipids get better, triglycerides. What can one expect?
Yeah, all of those things, plus improvement in metabolically associated liver disease. Their livers often just totally calm down and have no fat in them at all. And the other interesting thing is, and we kind of understand this more in the world of GLP-1 now, but leptin suppresses these individuals' hunger. Without leptin, leptin is one of the signals, just like GLP-1, that tells your brain that you need to stop eating. And if you're leptin deficient, you're always hungry. So many of these kids we used to see were just ravenous. They would just eat anything and everything. But you give them leptin, the metroleptin, and they're not hungry anymore. For whatever reason, many of them were depressed. And you give them leptin, and suddenly their energy and their mood is much better.
So other than metroleptin, other things or other treatment strategies that you invoke when taking care of patients with lipodystrophy?
So other than metroleptin, there's not anything super particular to lipodystrophy. If they have partial lipodystrophy, for the most part, we're treating them the same way we treat everyone else. We're using insulin for diabetes or GLP-1s. Actually, there are some small studies showing GLP-1s work for people with partial lipodystrophy. We're using fibrates, omega-3s to lower their triglycerides. We're doing kind of the same things we were doing for everyone else.
Do they need to have aggressive cardiovascular assessments? Someone comes in, do you consider screening for subclinical atherosclerosis, et cetera?
Yeah, you can consider that. It's very reasonable because these individuals are at a very high risk for cardiovascular disease. I'm trying to remember the data, but I think I remember that many of them have a cardiovascular event in their 50s or 60s, a little bit younger than average. And then there are also some forms of lipodystrophy are associated with arrhythmias. In fact, Detrogarg has saved the lives of several kids by diagnosing them and getting them ICDs or antiarrhythmic drugs, because they flip into these VTACs and all this stuff really quickly. So that's another reason to identify these individuals early, just so that you can avoid that. They also get cardiomyopathies, and so a good cardiac workup was important. Yeah.
Is there any specific diet that you would recommend for patients with lipodystrophy, and does it vary based on the type of lipodystrophy?
Yeah, the diet is kind of similar to what we tell people with high triglycerides in general. For the most part, it's a low-fat diet that is going to be high in protein and moderate in carbohydrates. And of course, they should avoid alcohol. We also tell them to avoid estrogen. I mean, that's not part of the diet, but it's part of the treatment overall. But yeah, diet is uh, diet is difficult to do lifelong. But we have seen some people who have been on the right diet since they were born because they were diagnosed early, and they do fine. They do really well.
I've seen two patients that were misdiagnosed with PCOS, who actually had lipodystrophy. So um, that's a great takeaway about the estrogen. Absolutely. Uh, and so, one of the questions I wanted to ask you as an endocrinologist, I'm an internist, but we're both lipid specialists also, is that there's really no specialty for people who just take care of lipodystrophy patients. And these patients often are seen by multiple specialists before someone actually makes the diagnosis. I recently had one of those V8 moments where I had been seeing a patient for a while before it dawned on me that she had lipodystrophy. And so I guess what would your suggestions be regarding institutions that don't have someone like yourself or Dr. Garg who are very focused on this as to how to identify these patients? Where might they show up, and how should one think about identifying them for obviously many of the reasons we've discussed today?
Yeah, it's similar to almost any or many other rare diseases where the presentation, especially in younger ages, can be a little subtle. But yeah, I always say these individuals do need a team. They need a primary care doctor to manage everything. They need an endocrinologist. They might need a geneticist. They need dietitians. But whoever you are, whatever clinic you're in, I mean, we've seen cardiologists diagnose these patients. We've seen gastroenterologists diagnose these patients. Dietitians sometimes are the ones diagnosing them. Many primary care doctors diagnose them. It's probably primary care more often than anybody else. But it's somebody who has probably seen a few pictures of what a lipodystrophy patient looks like, especially if you see a video, like something three-dimensional. I think this is more of a three-dimensional disease. Like two-dimensional pictures don't do it justice. You need to see what the arms and legs look like when the veins are popping out and the muscles are popping out. But the person has a triglycerides of 1,000, or they have diabetes, and it's pretty interesting. I mean, there are bodybuilders. Some of our patients have been bodybuilders. One of our patients was an Olympic athlete. She was always getting tested for doping because of her appearance. She was so muscular. It's very interesting.
As they say, hiding in plain sight, right?
Yeah, yeah.
So before we wrap up, what key takeaways would you want our listeners to remember when thinking about identifying, evaluating, and treating patients with lipodystrophy? If you could give them 3 or 4 bullet points.
Yeah, I think one key takeaway is, do an exam. If you see somebody with the metabolic complications of obesity, but they're not obese, they're not really obese or something, do a good exam. Take a look at their arms and legs. Um, you know, that Jagard makes people lower their pants and takes a look at their buttocks. There's a big fat pocket in the back of the buttocks that obese people have, but people with lipodystrophy don't have. It almost looks like a hollow in the buttocks. So that's a good diagnostic. Take a look at the calves and the forearms. Those are good places where you can pinch a little bit and just see if there's fat there. And another takeaway is if you don't see it, or if there's not fat, or if you suspect it, nowadays it's easy to get genetic testing, and I think it's worth it. I had a patient recently who, on exam, it was a male. So lipodystrophy is kind of hard to tell in males, but on exam, he was not obese. His forearms didn't have much fat, and his calves didn't have much fat. yet his triglycerides were 2,000 and never came down. And so we did genetic testing, and he turned out to have a PPAR gamma mutation, which is probably an under-recognized cause of lipodystrophy. So, exam genetics, and if you identify someone, get them to an expert, get them to a lipid specialist, get them to, uh, you know, the dietitians, the people they need to see, get them to a cardiologist to evaluate the heart. Those would be three kind of take-home points, I think.
To summarize for our listeners, we've had a wonderful discussion today with Dr. Zahid Ahmad, who is an endocrinologist and lipid specialist at UT Southwestern, discussing the lipodystrophy syndromes, of which there are several. He delineated the concepts of generalized versus partial, and then the concepts of acquired versus inherited or congenital. The importance of recognizing the cardiometabolic comorbidities that go along with this condition: fatty liver, diabetes, high triglycerides, early atherosclerosis, and obviously the physical findings that you so wonderfully, describe both in your early interactions with Dr. Garg and how you diagnose and take care of these patients yourself. The overview on understanding and managing all of the comorbidities with many of the interventions we already have available to us for blood sugar and triglycerides and heart disease risk, but also the importance of recognizing generalized lipodystrophy in patients with lower leptin levels, because they may be candidates for metroleptin, which is a newer therapy that is available for patients with this condition. And then lastly, I think your nice kind of understanding of the importance of collaborative care and the team. It takes a village to manage these patients, and they may not all be in one center, but you may not have a center at your institution, but you can find these people and make sure that they contribute. So I wanted to thank you for the excellent discussion, and thanks to our audience for listening. Please remember to take the post-test and evaluation to receive CME credit. And also, please tune in for additional episodes within this series. In our next episode, I'll be speaking with Dr. Don Wilson about the diagnosis and individualized treatment and management of patients with pediatric lipid disorders. Thank you very much.
Thanks again for listening to MedEdTalks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.